Welcome to Compass Opioid Stewardship in Practice. Each week, our Compass coaches will explore a real-world case, define a clinical goal, and walk through practical strategies to improve care. Whether you're tuning in via video, audio, or reading the summary, this session is built for busy clinicians like you. Enjoy the show.
My name is Rachel Duncan, and I'm a clinical pharmacist and coach in the Compass Opioid Stewardship Program. This week's case is part 2 of a series on a patient with chronic pain on chronic opioid therapy. I'll start with a quick reminder of our patient case. Mary is a 67-year-old female with chronic pain from past back and spine injury, which is now non-surgical, and peripheral neuropathy from her type 2 diabetes. She also struggles with longstanding depression, anxiety, and insomnia. She is obese with a BMI of 37. Her medications include sitagliptin and insulin for her diabetes, citalopram for depression, alprazolam 0.5 milligram tablets, which she can use up to once daily for anxiety or insomnia, and gabapentin and lidocaine patches for pain. For severe pain, she uses oxycodone 30 milligrams 5 times daily and is prescribed 140 tablets every 28 days. She fills this medication on time, every 4 weeks, and has never requested early refills. On further questioning, she reports having a drink or two, sometimes before bed, to help with sleep. Recent random urine toxicology immunoassay testing was consistent with medications prescribed. In part 1, we used Mary's case to discuss specific risk management strategies for patients on long-term opioid therapy who have increasing risk factors for respiratory depression and accidental overdose. In part 2, we will explore adjustments to our current medication regimen to optimize risk-benefit ratio. In addition to being prescribed a high daily MME, or 225, and having several other risk factors for respiratory depression and accidental overdose, there are changes that can be considered in Mary's current medication regimen that may enhance her benefit while reducing risk. To start enhancing benefit, the following considerations can be made. Since Mary is struggling with both depression and neuropathic pain, it may be appropriate to consider changing her current SSRI, or citalopram, to an SNRI, like duloxetine, to gain better pain control while still treating her mood disorder. You can offer her a simple cross taper by cutting her citalopram dose in half when starting the duloxetine, then stopping the citalopram when the dose of duloxetine is increased. In addition, Mary admits to struggling with sleep and insomnia. We know that there is a bidirectional impact of sleep and chronic pain, so improving one will improve the other and vice versa. Right now, Mary is self-medicating with alcohol to sleep, which we've reminded her is contraindicated and prohibited per her CSA. Introduce Mary to a free online cognitive behavioral therapy, or CBT, insomnia application that she can start using to improve her sleep in a non-pharmacologic, evidence-based way that is considered gold standard for insomnia treatment. Advise her that using a benzodiazepine, such as her alprazolam, is not ideal and is risky alongside her opioid use. If she is unable to cut down on and off her once daily use of alprazolam, offer to switch her to a longer-acting benzodiazepine, such as diazepam or clonazepam, that may make tapering off less painful. You can also discuss with her the use of non-benzodiazepine agents that can be considered for insomnia, such as trazodone or hydroxyzine. But emphasize that CBTI is by far the most effective and least risky approach for long-term success. In addition, recommend cognitive behavioral therapy or a pain psychology consult if available. Mary would greatly benefit from psychotherapy for her depression, anxiety, insomnia, and chronic pain. Learning coping skills and empowering Mary to be back in control of her mood and pain could provide significant benefits. Discuss with Mary the potential that her opioid agent, her oxycodone, is likely contributing to both her sleep disruptions and worsened mood and depression. Engage with Mary in conversation around what it might look like to rotate to an agent that is still effective for pain management, has minimal sleep disruptions, and has been shown to improve mood and depression, all while lowering her overdose risk. That agent to consider is buprenorphine. In addition, buprenorphine has been shown to be effective for the treatment of neuropathic pain, for which oxycodone is ineffective. Send Mary home with a patient handout on the benefits of switching to buprenorphine. Now that you've identified that there are likely some changes that need to be made in Mary's care, lean into your motivational interviewing skills to assess for and increase her willingness to change. Though you may start with only one change at today's appointment, start preparing Mary for upcoming changes by discussing options, sending home patient handouts, or other materials on potential upcoming changes, so Mary can feel educated and ready to engage in shared decision-making. The clinical pearls we want you to remember are: review medication lists for potential optimization opportunities by looking at agents that may be appropriate for multiple conditions. Identify medications that may be becoming more risky as a patient ages and offer alternative therapies. Make sure you have several options to present to a patient, empowering them to make the choice in how they want to proceed next in their care. Provide education and handouts on new therapies or medications that may be more beneficial for the patient. And use your motivational interviewing skills to prep patients for future changes in therapy. The Compass OPSS program provides resources to help. For more personalized technical assistance on this topic, we encourage you to reach out to your clinical coach to schedule a coaching session. Thank you.
This show has been brought to you through the generous support of the Centers of Medicare and Medicaid Services. Thanks for joining this week's Compass Opioid Stewardship in Practice. Thank you for being part of the Compass Opioid Stewardship Program, and thank you for all you do caring for your patients. See you next time.